Hello people! Today we're discussing how to do the cervical flow. Essentially there's two cervical flows, one that concentrates on the upper cervical region and then one that concentrates more on the lower. Essentially we're going to do the upper cervical region assessment flow. You do that more if somebody has pain to the suboccipital region, they have pain with rotation, they have headaches, they have dizziness. Those type of signs will suggest upper cervical dysfunction. I also forgot to mention TMJ. But most of the time, patients come in here and they have more lower cervical presentations. Essentially, that'd be pain with either flexion extension or side bending, or they get an upper trap tightness. Any person has pain around here, and a lot of people come in and say, hey, I have shoulder pain, and if they point over here, it's really more the neck than the actual shoulder. So this is when you do your lower cervical assessment. So the biggest goal is to find which quadrant is the limitation in. Right? What is the quadrant of limitation? When I mean quadrant, it can either be extension, side bending left, extension, side bending right, flexion, side bending right, or flexion, side bending left. So it's one of these four diagonals. So once you establish that, then you try to look for why the person has pain with that quadrant, and there's many different possibilities. So in a nutshell, if somebody has limitation in a quadrant, it could be due to a tight capsule, it could be a subluxed segment, it could be tightness of the individual segmental muscles, it could be global tightness, and that has different causes. There's a tight dura, right? It could be due to instability, guarding for instability. It could be a driver somewhere else, kind of causing the whole dysfunction to manifest itself. So it's easily like 8 different reasons why you might have limited range of motion. So it's very important you know how to tease it out. So it all starts with range of motion assessment. Okay. Can you actually face that one, please? This is Esther. Say hello, Esther. Okay. Okay. So the thing is, you always do your observation. The biggest thing is does someone kind of tilt the head naturally, stuff like that. You're palpating to see what is tender. What is tender will tell you which segment is usually hypermobile, right? And then you look at those tight muscles and tell you why is that person guarding. So after you do that, the main crux of it is doing range of motion assessment. When you do range of motion assessment, right, it's much faster if you guide the person. You tell the person to do it actively, but you kind of guide them. So hey, look down for me, look down, look down, look down. Okay. Then hey, look up for me, look up for me, look up for me. Okay. And then tilt your head this way, and tilt your head this way. Right. Your whole goal is to pick up pain. Their pain, not any pain, but their pain, which is what they come in here for. But a lot of times when I miss things, when you look down like this, you should really bias the upper neck from the lower neck and also from the upper thoracic region. So the way you get the upper neck is have the person just do a chin nod. So okay, can you just do a chin nod? Okay? And then lower neck is simple, is looking down like this. Okay? And the upper thoracic is really have them go all the way down. Same thing for upper cervical extension. You put your hand over here by C2 and tell, hey, look up over here. Put your hand on T1 to get the lower cervical to extend. And to get the upper thoracic, you have the person go all the way back. So once you find which one causes the person's pain, you want to see which combination bothers them. So let's say if side bending bothered her, does it get worse with flexion? Does it get worse with extension? Okay? Or if you have pain with flexion, does it get worse with side bending right or side bending left? Okay. And then your whole goal is to see which of these 4 quadrants is the main one. I'm pointing down for it. Okay, so Dwayne behind the camera. I don't know what his problem is. So anyways, the thing is, let's say this is the quadrant of dysfunction. Okay? Can you see that? Is the button in the way? Should we cut it here? No, it's okay. Okay. Alright. Okay. So let's say that's the dysfunction right there. Alright? So the first thing is you want to know if it's a muscle limitation or if it's a capsular. So very simple we do, you notice I put it at end range. I'm not cranking on a person's neck like Dwayne would like to do. Just go to there and just raise your shoulder up and see this get more motion. In her case, she gets more motion. But you also just should do the same thing on the other side. Do you see you get more motion? Okay? So once you see there's more motion, there's a hypertonic muscle driving this whole thing. But it must be hypertonic for many different reasons. So one of it is tight dura, because whenever you depress your scapula, you're pulling on the dura. So if that bothers you, you will kind of elevate your shoulder to take the pressure off the dura. And in order to do that, you have to use your upper traps, and therefore that muscle will be on all the time. So the way you see if it's the dura, very simply, you take the person to the quadrant over here, okay, and then you put the person in the position of dura stretch. Right? So for example, let's say right here she gets pain. I ask her, hey, does this make the pain worse? Okay, right. And the key here is to really make sure that you really depress the scapula as you're doing this. Okay, do the same thing both arms. Right? If that was positive, you have to do a dura assessment, right? Which we'll talk about in another video. But let's say that was fine. The next thing that could really drive this activity dysfunction is an instability. Right? So if you're moving this way over here, your vertebra is supposed to translate in the opposite direction. Also, when you're extending, your vertebra is supposed to translate anteriorly. So it's a lot of work to assess each segment. So sometimes it's easier just to give general stability to the whole entire neck. So what I'm doing over here, okay, is I'm just holding on the neck. It's giving nice stability and a little lift, right? And then have the person move back and ask, hey, does that feel better? If it does feel better, that tells you, okay, it's an instability, but which segment's unstable? So this is when you do segment by segment, and you ask yourself, which segment does it feel is translating too much? And in her case, I feel like on C4, it's moving too much. So what I'm going to do is gently try to reposition it, and then move back to see if I get more motion. Right? If I get more motion, that tells me that C4 is moving too much excessively to the right. So then I have to do an instability assessment. One of the first things you do is, whenever you notice instability, is what's going on with the muscles. Are the muscles doing their job? So is the longest colli doing its job? So you have the person do a chin nod, not a chin tuck. The chin tuck causes too much shearing. Chin nod, and then bend back to the left. See, that improves the motion. If that improves the motion, that means the longest colli is not really doing their job. Otherwise, multifidus. You palpate the segment in which you felt the weakness. You do a shoulder motion, a contralateral side, and you resist manual muscle testing, and you see the multifidus kicks in. Okay, and then you do the same thing with the other arm. You see the multifidus kicks in. Right? You're looking to see for three things: does it initiate? Okay, does it initiate on time? All right, it should pre-fire before you move your arm muscles, and then lastly, endurance. Can it last more than a few seconds? Okay, so that'll tell you about the deep muscles. But hey, is superficial muscles doing their job? So you put the person in that position over here, and you're really concerned about the outer muscles. Can they prevent this motion? So you just do MMT. Hold it here, hold it here, hold it here. The muscle is strong. That tests the strength of the global muscles as stabilizers. But then you need to know, does it work well with dissociation? So what that means is put the arm back and forth, have the patient move the arm back and forth, and do they fall into that pattern, right, of extension, side bending left? Because this motion here is what? Using your mouse all day. But the thing is, the key word is all day. So you might not see something during assessment. So to kind of tease it out more, you deal with resistance. So I'm going to resist her into flexion. Push, 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 push back, push back, push back, push back, push back, push back. Okay. Right? And do I see anything? And you're not quite sure what people do at work, so it's good to just do all 6 motions of the shoulder. Actually, 8 motions of the shoulder, and see if any of that causes excessive motion in the neck, and that tells you the person needs dissociation testing. So all that was just for instability. But suppose that didn't help. There might be a driver. Right? So the driver here could be a scapula, a reposition scapula in the right position, and have to move the person back. I do the same thing over here. Put the scapula in the right position, and then move them back. If that doesn't work, I look at the thoracic spine. Right? The key is the thoracic spine in the right position. Okay? A quick assessment is by putting my hand on the ribs, move side to side. Think of the ribs as long transverse processes, and you're moving side to side, and you're looking for hypermobility. Looking for hypermobility. Looking for hypermobility, right? Once you get over here, the scapula gets in the way, so you kind of get in between the scapula. You see if there's any hypermobility. So for example, she has a hard time over here moving her T4 to the left. So what do? I move it to the left and hold it there. So we call this stacking. reposition it, stack it, and have the person move back into a quadrant. See if that helps. If that helps, that tells you I need to assess this. Right? In particular, if you find this to be the limiting motion, you can't go to the left, we translate left in order to side bend right. So I'm going to assess right side bending. In her case, she's pretty hypo here. So if you can't side bend right, is it because this side can't close or this side can't open? So what do? You assess right side bending extension and flexion and see which one's worse. Right? Which one's ever worse tells you the side dysfunction. So the acronym they use is FOES, flexion opposite, extension same side. And then you start doing your thoracic assessment there. Okay. Lastly, let's suppose all that was if this improved the motion. Okay. But let's suppose you did this and the motion did not improve. You think it's more of a local capsular problem. So what you do is you stabilize each segment and you move into that quadrant. Right. So I'm gonna hold C2 and then move her whole head into that quadrant. Hold C3 and move into that quadrant. What I'm doing, comparing one segment to another, and tell me what the stiffness is. For an ester, when I hold C3, C2 is pretty stiff. When I hold C4 and 5, it moves pretty well. Okay. The key here, make sure you keep don't let the chin do this, right? Because if you do this, you just get a whole bunch of extra motion. So really trying to do a little quadrant, right? Motion. So lie down back. Okay. Can you zoom in here? Okay. So once you figure which segment is stiff, right? In this case here was extension side bending. So I extend that segment and then I do my cervical assessment. And I'm going to do an imp here on the Z joint, and then the opposite side I'm going to go on the U joint and then do a SAP. Right? The main one we're on this side is anterior motion. This one here, the main thing is doing the inferior motion. And I'm assessing the segment, looking for the end field, so comparing to each segment. So once you find a segment that is hypermobile, you look at the end field. My three choices are boggy, capsular, or hard. Hard in the case of fixation, they mean manipulation or mob or mulligan technique. If it's capsular, you just need to mobilize, and then if it's muscle or bogginess, you just do a muscle energy technique. Okay, so once you treat it out, get the person back in sitting and reassess motion. A lot of times they'll unmask another problem and you continue that way. Regardless of which technique you do, you should know what was the proper HCP to get there. So in summary, I show you that someone can't move into a correct motion. Once you find the quadrant, it could be due to a capsular tightness, subluxation, it could be due to bogginess of a particular muscle, it could be global muscle tightness, it could be dura, it could be a driver, it could be instability due to weakness to the multifidus or the lungs cola, global muscle. So there's a lot of different ways. Most people have more than one. So the whole goal is to tease it out and see which one the person has. Okay? We'll make other videos that will talk about more closely how to do IMPs and SALs. Right? We'll make more videos on how to do dura assessments. Okay? And I'll see you guys later.